Hello everybody, I wanted to go through and give you just a quick rundown on some of the cancers of the GI tract, as well as a few slides about trauma in the GI tract. We have studied cancer in pretty good detail last semester, so I won't belabor too many points, but I just want to make sure that we talk a little bit about GI cancer because it is a fairly common and in many ways sometimes a fairly preventable type cancer. This just kind of talks a little bit about the cancers of the upper GI tract. You can see from these statistics that oral cancers are a small percentage. However, men are much more likely to be affected than women, and you might ask why. That tends to be specific to tobacco smoking, as well as dipping and using snuff and chewing tobaccos, which are much more common for men. There are two basic types: squamous cell carcinoma, which is the most common, and sadly it grows very rapidly and is easy to metastasize to other parts of the body, as well as very deep into the face and affect other parts of your mouth, throat, neck as well. Basal cell carcinoma is slower. Sometimes you see that a little bit more with exposure to the sun, and we see that on the lips sometimes, and then it develops further. And again, men tend to work in jobs sometimes more frequently than women where they're out of the sun, once again making them a little more susceptible. You can kind of see the basic locations. Usually you see more in the floor of the mouth than you do in the upper palate to begin with. There are also two different types of esophageal cancer. If it's in the upper portion, it tends to still be the same squamous cell carcinoma that you would see in the oral cavity. But in the lower segment of the esophagus, you tend to see more adenocarcinomas, and those are also consistent with the types of cancers that you see in the lower GI tract as well. Again, smoking, exposure to sun, a lot of the focus should be on reduction in smoking because it's really the cause of over half of the cases. So just to kind of be aware of that in teaching. These are some signs of oral cancer. You know, we've looked at lots of types of mouth sores and ulcerations. These tend to be a little bit more distinct in that, you don't see white all over their mouth like you see in thrush. You see these white type spots usually in the lower part of the tongue or in the lower part of the mouth that are called leukoplakia, or you may see very bright red lesions that would not look real normal and would be a lot more noticeable, that are called erythroplakia. And then with some patients you see a mixture of those type of lesions in their mouth. These are some of the clinical manifestations for oral. Early symptoms, again, affect the floor of the mouth or the tongue. You may see bleeding. You may see raised area on their lip or in their mouth. Often these ulcerations will not be, round. They may have uneven margins and edges, and that makes them even more suspicious. Again, white or red patches. Patients may have pain that radiates to their ear or their neck. And as it progresses, they may have difficulty swallowing, difficulty speaking and chewing. They may develop an oral smell that's kind of difficult to handle. And then it may spread to lymph node involvement. You start to see glands that are swollen, and often weight loss because of inability to swallow, chew, and then some patients that have had dentures, suddenly they just don't fit the way they used to, or they're so tender they're not wearing them. In terms of esophageal cancer, the biggest thing, most common symptom is a progressive decrease inability to swallow or have difficulty with swallowing. The sad thing about esophageal cancers are they go asymptomatic for a very, very long period of time till a tumor has occluded almost half of the esophagus. And often there's already mets that have gone to the lung, liver, bone, stomach, cervical lymph nodes, or other sites. And just as you can see, the overall 5-year survival rate is from 5 to 30%. So a lot of the treatment for it is going to be less extreme and more palliative in nature because of that. Again, difficulty swallowing. You may see hemoptysis and coughing up blood. Pain or burning is usually in the middle part of the chest. They will be swallowing foods okay until the food or liquids actually reaches the tumor site, and then it's very painful when that occurs. They may have vomiting, weight loss, lack of an interest in eating because nothing seems to be feeling like it's passing, and then they many times will have a symptom of hoarseness or a change in their vocal sound that alerts them there's an issue, and then they may also have blood in their stool that's usually dark because of the distance that it's traveled. In terms of management, the treatment for oral cancer is going to be dependent on the size and the stage and where it's located, the patient's overall functional capability and level. If there's mets already, they may not be as aggressive. Often they will use radiation therapy either as primary or secondary to kind of either shrink the area or treat it after surgery to kind of make sure they've gotten everything. Obviously, medications are given in terms of managing pain and discomfort, and chemotherapy agents as well. Surgical, they can have little small lesions taken out under even local anesthesia. Larger ones require general anesthesia. And then there's for real small lesions, they can also do a few other things where they laser it or do cryotherapy or photodynamic therapy to remove it without extreme surgeries. Esophageal cancer, as I said earlier, it's usually diagnosed by using a barium swallow, a CT scan. They will use a PET scan to look for more small mets in the different areas of the body. They often will use ultrasound to kind of see where the areas go from normal to abnormal tissue. And then they can do a thoracoscopy or a laparoscopy, a scope procedure with instruments through the endoscope into the chest or the abdomen, wherever is necessary to try to take samples to see if it really is cancerous. For non-surgical management, which is what a lot of these patients get because it's usually too far gone, they usually have complementary and alternative medicine type treatments, and those are a few that are listed. For surgery, because it's so uncommon that it's found early, they can do some surgery for curative purposes to remove the tumors, and they will usually go ahead and take out the lymph nodes and any surrounding tissue. But more often it's palliative surgical interventions just to kind of keep that area open a little bit so that they can have nutrition as long as possible through that route. Complications for oral, you tend to see infiltration into the underlying tissue of the face. It can be up into the sinus cavities. It can be up and affect the eyes and have to have eyes removed. And some of these patients will have huge, big indentions and portions of disfigurement on their face. For esophageal, Occasionally they can, that the difficulty with the swallowing that they see is due to where they've done some surgery to remove something if they got it early, and therefore even with surgery they will often have ongoing complications. They always have heartburn. We talked about the pressure that's kind of coming back, and that will cause them to have like GERD-like symptoms. They will have frequent nausea and vomiting because their stomach emptying and the nerve involvement from the surgical procedure. And then, again, they're pretty high risk for potential for bleeding and rupture of the esophagus. In terms of gastric cancers, diet is the most significant reason and cause, I think, behind gastric cancers. It's highly associated with people who eat smoked foods, pickled vegetables, salted fish and meat, and dietary nitrates. It's more common in lower socioeconomic groups. It affects males 2 times more than females. It's more common in patients who have condition states of achlorhydria, which is a low gastric acidity type state in their stomach. There's a type of gastritis that we'll talk about tomorrow that when there is metaplasia or abnormal cells present, and the patient has pernicious anemia with that type of gastritis, they're more likely to develop gastric cancers, but a lot of the cause is still unknown. What happens is you have malignant epithelial tumor that kind of infiltrates the mucus-producing cells of the stomach. It's most frequently found in the distal portion, and again, there's some chronic gastritis and atrophy that are often at the cause of this. Often you will see patients be very asymptomatic until very late in their course. Some of the symptoms are listed here. They may think that they have an ulcer for a long period of time, have weight loss, indigestion, develop an abdominal mass, have nausea and vomiting, and then they may be losing blood from this cancer in the stomach. And so then you may see them be anemia from that, or have melena or tarry stools that'll have a foul odor occasionally, but that's less common. Pain is often unrelieved by antacids, and it usually is worse after a meal. So, having those kind of ideas in terms of your assessment is always good when you're trying to research any kind of pain, to try to differentiate this from GERD symptoms or other type symptoms. In terms of management, diagnostics is a wide variety of things. Again, barium X-rays. They may do an EGD with a biopsy. There are some gastric secretions that they can withdraw during a scope and send those for cytology to see what the cells look like if they're cancerous in nature. Laboratory studies, often they're going to do CBCs, again, to look to see if there's any low hemoglobin or hematocrit or signs of anemia. Surgical management, we know that this dysplasia that shows up in the stomach is usually the precursor to gastric adenocarcinoma. And the more severe the dysplasia is, then a gastric resection is considered. In the early stages, they can do that laparoscopically and then just administer some adjuvant chemotherapy with anthracycline, one of those that's called 5-FU, you'll hear people call it, and they may do radiation. These patients, when they have a partial gastrectomy or a partial removal of the stomach, will have a very concentrated chyme, which is their undigested food, and it's like going into the small bowel very fast, having something called dumping syndrome. And when that occurs, it causes a lot of discomfort, abdominal distension, and then